Okay, good evening, everyone. This is I Care for Your Brain with Dr. Karen Sullivan. That is me. I am very happy to be a board-certified neuropsychologist. I have been with you since November of last year, every Wednesday, 6 p.m., giving you a free brain health lecture to the best of my ability, because I really believe that a layer of distress and disability with all brain health challenges is a lack of access to scientifically based information that will help you make sense of your symptoms and will give you the best roadmap on how to navigate your way through your recovery to reach a point where you feel that you have the highest quality of life possible in that long journey into recovery. Tonight we're going to continue with our lectures on stroke. And one of the things I love about being a neuropsychologist is that we are trying to understand things that aren't really obvious. They're not necessarily easily measurable on the outside. We have very sophisticated paper and pencil tests that we use to infer functioning of the brain, but it's not something you can really measure with a blood test or by doing a reflex test, right? These are things like cognition, mood, adjustment. And within the world of stroke, there's a lot that happens, of course, besides physical symptoms. The problem is it's very easy to just focus on what we can see, what we can measure, right? So too often I think that recovery gets focused on the physical issues, the sensory issues, what we can see. And as a neuropsychologist, I really like to take more of a personal kind of behind the scenes look. And so what we're going to focus on tonight are some of the mood changes that happen after a stroke, specifically the topic of post-stroke depression. So after a stroke, there are a whole range of symptoms, of responses, of adaptations, adjustments that are completely normal, right? There's nothing that is really abnormal. The problem becomes when over time you kind of get stuck, and something about that stuckness, whether you're stuck in depression or anxiety or bitterness or resentment, makes you not able to participate in your rehab therapies to the point where you're going to best benefit, keeps you isolated away from the world, and maybe even is exacerbating the underlying symptoms that are there from stroke. So a lot of these reactions are universal across people who have had strokes, and they can include things like shock. You know, a stroke is a traumatic event. For most people, it comes out of nowhere, and there's typically not this feeling like I am going to have a stroke at some point in my life, particularly if you feel like you're a healthy person, if you're a younger person, right? That's just not something that you were anticipating happening. So there can be a sense of almost like, is this even real? There can be a feeling of confusion. The hospital setting, there's so much coming and going, and you're being told so many things, and there's so many new faces and people that it can be hard to keep things straight. People can feel very angry. You know, why me? Why did this happen to me? I played by the rules. I did everything I was supposed to. People can feel blaming, you know, why didn't I listen to that recommendation to exercise? Why didn't I take all my medications perfectly? People can feel extremely fearful of having another stroke. There can be a ton of anxiety about, will this happen again? That's even something that is very common years later, 5 years, 10 years, 20 years later. Sometimes people feel an enormous sense of gratitude. There's a feeling like, thank God that I lived. I'm so grateful to be here. Even if I have some impairments, some limitations, I'm just so grateful to have made it through the stroke. So I want this time together to be interactive. So I would love to know from people who have been there, what were some of your very first reactions when you were in the hospital, when you realized that you had had a stroke, when you were told that you had a stroke? Was it a sense of shock? Did you feel angry? Did you feel confused? You know, what was it that specifically went through your mind? Because of the stroke, we can have a wide range of emotional reactions besides just those specific symptoms. The whole emotional system can get a little bit dysregulated, and we can have a limited range of emotions. For some people, they just feel kind of flat. There's like an emotional blunting. They feel almost numb, like overwhelmed, like they can't experience the full range. They feel like they're on pause, right? They can't experience the full range of emotions. For other people, they have very strong emotional reactions. We call this lability, when one minute you're laughing, the next minute you're crying, one minute you're mad at someone, the next minute you want to hug, you're kind of all over the place. We can also have perseveration. This is when people get stuck on one topic or one emotion and it just seems to go around and around. I think of like a hamster on a wheel. We can also have initiation issue, which is kind of a disconnect between what's happening inside you and what you can express on the outside. And these things are kind of the setting for our emotions. That's kind of the inner workings of our emotional system in the brain. And then, of course, we have our normal human emotions on top of that. But tonight, what I really want to focus on is, the so-called darker emotions, the more disabling symptoms of depression. We're not talking about occasionally feeling down, feeling like you need to rally and really, get yourself pumped up to be, facing the world. We're talking about something that is much more significant and serious than that. So this is the most common mood disorder after a stroke, but more than half of the people who have it are not properly diagnosed and are not properly treated. Yet it is the main limiting factor in recovery and rehabilitation after a stroke. It definitely leads to greater disability and reduces quality of life in all ways. Cognitively, of course, how you feel emotionally, your social health, your increase of mortality goes up by about 10 times if you have untreated depression. That means you're 10 times more likely to die in the 3-year span after a stroke if you don't have your depression acknowledged and treated. Early treatment of depression that we're going to talk about tonight enhances all aspects of recovery. So this goes, you might not know it, but some treatments for depression actually help physical recovery. And a lot of times in my practice as a neuropsychologist, I use this information to my benefit because some people who are depressed don't like that label. They don't want the treatment. They think the idea of taking antidepressants, they label it, they judge it negatively. But if I can convince them, it might also help get some use of their arm back. I've got another inroad. So tonight I want to teach you all about the benefits of treatment. And really the point of this lecture tonight is if you have had a stroke and you have not assessed yourself or been assessed for how your mood is, you could very well be missing out on a way to enhance your recovery. So post-stroke depression has been around in the scientific literature for about 100 years, but it really wasn't until the 1970s that high-quality studies started to happen. And when you look at the literature, there is a wide range of percentages of people who they think go on to have depression. And this has ranged anywhere from 25% all the way up to 79%. That is a big, big, big change. So part of that is because the quality of the studies were different. They took people with different types of stroke. They took different age people. They used different types of questionnaires to get at depression. Depression is very unique to, there are some common symptoms, but everyone experiences depression differently. So it's really been more of a question of, are these studies really tapping into the right questions with the right people at the right time? And does that match on to your experience? But a few years ago, there were 2 meta-analyses where they looked at over 25,000 people who had stroke, and they think the more accurate number is between 29 and 31% of people 5 years from stroke to when they were tested will have clinical depression at some point. And it seems to vary according to the setting. So when people are in the acute hospitalization phase, this is after the emergency room, if you get admitted to the hospital, they think the numbers are anywhere from 23 to about 40%. Once you hit rehab, these numbers can go up to about 70%. Outpatient, this is about 6 months when you get out of the rehab setting. It stays steady at about 26%. So what does this tell us? The highest point of depression seems to be in rehab. Part of the reason we think is because this is when reality sets in, right? This is when your symptoms are staring you in the face. In the acute setting, like I said, it's hustle and bustle. There's a lot of people coming and going. In the rehab, you're hit with the hard work of recovery. A lot of times the medications that they maybe had to get into your system to stabilize you have been stopped, and you're just kind of seeing things a little bit more for what they are. So we need to do a great job while people are in rehab in assessing mood and really reaching out and making sure they're not developing a depression. So why do so many people have it, but it is poorly assessed and diagnosed? Well, Really, it's complex. Doctors aren't asking the right questions, and a lot of times there's overlap between stroke symptoms and depression symptoms, and to the untrained eye, that can be indistinguishable. It can be very hard to know, is this sleep problem from stroke or depression? Is this trouble concentrating from stroke or depression? Is my loss of appetite because I'm depressed or because I can't smell because it's related to my stroke? Other times symptoms, I think, are unfortunately explained away, like everything becomes part of the stroke, right? Ageism sometimes plays a factor here. Well, they're older. They might not be able to go back and live as independently as they were. People can project that they're having a normal reaction when really, yeah, it might be normal in some way, but the severity of it and the impact on the person's self and their quality of life is not okay, and it can be treated. Symptoms of post-stroke depression typically happen within the first 3 months. We call this early onset post-stroke depression, but also, of course, they can happen at any time in the person's life. So post-stroke depression is not just feeling down every now and then. It is a clinical disorder. You require multiple symptoms over a course of a few weeks. You have to have a depressed mood or feelings of apathy. Apathy is that blah, I don't care, I can't care, I'm overwhelmed, for at least 2 weeks, but also 4 other symptoms. So I want you to listen and see if this pertains to you. This is, and it's funny how it kind of goes either feast or famine for different types of people. So appetite, either you can be ravenously hungry all the time, or you can want nothing to do with food. You can gain weight, you can lose weight. You can sleep too much, you can sleep too little. You can feel very physically weighed down and heavy. You can feel very physically restless and agitated. You can feel very worthless, feel very hopeless, feel like you can't concentrate, you can't make decisions. You can feel like you'd be better off dead, right? You can spend a lot of time thinking about what it would be like to not be here anymore. Symptoms of depression have to be severe enough to where they interfere with your functioning. So this is either your ability to participate in rehab, your ability to participate in family life, your ability to get things done around the house, and it's above and beyond what is happening to you with stroke. Post-stroke symptoms of depression, really all symptoms of depression, are very, very individual. No two people's stroke is the same. No two people's brain injury is the same. No two people's depression is the same. There's not one way to be depressed. You don't have to be suicidal and on the couch. Some people are very depressed and you would never ever know it. They can put on a great show. But the way I want you to think about symptoms is really in 3 different areas. So the first one is physical. So when we are depressed, we have a very low energy feeling, or that feeling like we have so much energy we're ready to bust out of our skin. That's where the too much sleep, too little sleep comes in, feeling like I want to eat everything or nothing appeals to me. We also then have cognitive symptoms. This is the way you are thinking, having trouble keeping your thoughts straight. It's that idea of brain fog, right? And then of course we have mood. Mood is feeling sad. Mood is feeling numb, feeling guilty, feeling unlovable, right? It's hard to tell if somebody is depressed. Not everybody wears it on their sleeve, but I think universally the way depression is best described is a feeling of being kind of chronically overwhelmed and you just don't have the energy to cope. The real danger of depression is the downward spiral that happens when we are depressed, right? So when we're depressed, we have a problem like bad sleep, right? We can't concentrate. Well, then during the day, our coping is going to be poor. And then we're going to ruminate and we can't get things out of our mind. And guess what? You're also going to have trouble sleeping, right? And this pattern goes on and on and on to the point where the negativity and the despair, it just gets worse and worse and worse. And each symptom is really aggravating the other. So I wanted to talk to you a little bit about what scientists think is the cause of post-stroke depression. And there's been debate over this. Is it all biology related to the stroke? Is it all adjustment related to the psychology? Or is there some way that these two things are interacting? Well, there is evidence that supports what we call the biopsychosocial model. So what the bio part means is that there is actual chemical, physiological things that happen in the brain that do make it more likely that somebody may have depression. There's also the psycho part. This is referring to people's personality traits that predispose them to maybe thinking negatively, that generally make them not cope well with stressors and trauma. And then there's the social piece, the change in identity that goes from being a healthy, independent person in the world to being sometimes considered a disabled person. No one knows, including me, what it's like to walk in those shoes until you have really been there yourself. Now, of course, the combination of these factors is unique to each person. Within the biology piece, there are these genetic factors. I kind of referenced that. This is the genetic variations that neuroscientists think we're all kind of born with. And, you know, there's a stressor, and neurologically, genetically, we are kind of prone to being more vulnerable or more resilient, right? So people can experience the same traumatic stressor, and sometimes there's people that just can cope with it and see the silver lining and can go on, and there's other people who have a trauma and they feel really broken and they get very, very down, and life seems to be forever changed. Some of those things are hardwired. Also, our medical history comes in here. So this is if you have a history of heart disease, hypertension, uncontrolled diabetes. There's a lot of research going on right now about how those conditions affect the small blood vessels in the brain that are in a big old circuit with the frontal lobes, and that when people have damage in that part of the brain from too high of blood pressure, uncontrolled blood sugar, that we get some lack of blood flow to the frontal lobes. And the frontal lobes are really what give us our initiative. I think of it kind of like your gas pedal and your brake pedal. When you have vascular disease in your brain, which is the number one set of risk factors that sets you up to have a stroke, you can have what they call vascular depression. And this is, you don't have that feeling of initiative, of interest. You have a lot of brake, but you don't have a lot of gas pedal. And then, of course, there is the psychiatric mental health history you brought with you into the stroke, right? The stroke isn't the only or first bad thing that has happened to you. Trauma is cumulative. So the more trauma you've had before your stroke, the more likely you are to be traumatized by your stroke and be depressed by it. How much actual stroke damage, like ischemic versus hemorrhagic versus different parts of the brain that are affected, this has been a source of great controversy in the literature. And back in like the 70s and the 80s, they thought that stroke location and severity of stroke had everything to do with depression. But the only thing that's really been consistent in the literature is that folks who have a stroke in the left frontal lobe or the left basal ganglia seem a little bit more likely to go on to develop symptoms of depression. This isn't surprising that we haven't seen a huge association with mood symptoms and neurological symptoms because of how complex the brain is and how different everyone's brain is. You can't lump 30 people in a study with brain damage and think you're really looking, it's apples and oranges, right? So there is one thing though about the actual brain damage that 100% affects a lot of things after a stroke, including mood, and this is changes that happen in the neurotransmitters. These are the chemical messengers in the brain. Specifically something called glutamate. So neurotransmitters, are basically, they help balance out our mood. They can either be excitatory, which means they get things going, right? That's a little bit of that gas, or they're inhibitory and they make things stop. Well, there's something called glutamate, which is the most common excitatory neurotransmitter in the brain. And we're really good in our healthy brain cells at kind of like eking it out when we need it. If the dam breaks from some type of brain injury, including a stroke, it can really flood brain cells and it can do a lot of cellular damage to them. And basically it just interrupts cellular respiration. And so the brain cells have damage even to the point of dying because they're basically being flooded by a chemical that really it only wants in little bits and spurts when it needs it. So what are some predictors that are related to the symptoms of stroke? So now we're moving beyond the neurological, but the actual symptoms. So people who have physical disability, cognitive impairment, specifically trouble with language, seem to be more set up to get depression. There are other factors that have been thought to be influential, including a lack of family or social support. I know that so many of you struggle to feel like people in your life understand, and that it's either like feast or famine, right? I feel like some people connect with me on here and feel really, really supported and really loved and held and well cared for, and other people feel like they really have to get their support from Facebook groups and other people who have really been there. So there's definitely evidence that if you don't feel supported, that you're more likely to become depressed. Other things have not been associated. It doesn't seem to matter how old you are. It doesn't seem to matter if you're a man or a woman. It doesn't seem to matter how much education you have or if you've had a stroke before. Depression is very significant. I think I might have just lost you all for a second, so hopefully not. Take that opportunity to hydrate. The costs of untreated depression are very real. People who go untreated have less participation in rehab. They have memory problems that are worse than they would have if they didn't have depression. There's more brain atrophy. They lose more brain cells because of the stress of being depressed. It's poorer quality of life for both the patient, the person, and the caregiver. So this isn't just affecting the person who's had the stroke. So why seek treatment? Well, it really very well may be a barrier towards your optimal recovery, right? You are here listening to me because you're like, ooh, stroke, ooh, brain injury. I want all the tools. Give me the information. That's why I love being here. It's a perfect match between someone who wants to share their knowledge and their support and people who are really craving it. I think that's why we've had such a successful time building up this community here on the I Care for Your Brain page. I think it was something that was needed, I hope. Mood is considered the strongest predictor of quality in life when you have had a stroke. So if that doesn't convince you to think about this and to take it serious, I'm not sure what will. There's 3 different options that you can think of for treatment. Counseling of all different kinds. I'm going to tell you what I think is the best in a minute. Antidepressant medications. I think you will be amazed when I tell you about some of these studies. And then, of course, self-care, right? Nothing that comes from a pill or another person. What can you do? How can you take responsibility? Well, like all things we talk about on this page, you have to start with a good assessment with the right professional. And I know that that can be a challenge. But we need accurate diagnosis. We need to know, is this depression? Is it anxiety? Is it post-traumatic stress disorder? Is it really all just my physiological stroke symptoms? You need to assess how you're feeling, write it down, and respectfully communicate it to a provider. A provider can be a psychologist, a social worker, a counselor, your rehab doctor, a neuropsychologist. You can talk to your PCP, your primary care doc, or your GP to get a referral to someone who understands mood. What can a psychologist offer you? Well, I think we're really good at pinpointing what is going on. We have a chicken and an egg, right? A stroke and depression. If it's there, what is really attributable to what? We can identify what your current coping skills are. We are all coping every minute of every day. You can be coping well, or you can be coping poorly. You can have adaptive coping, and you can have maladaptive coping. So we're all doing it. You need to know what are the coping skills you're using, right? Do you pretend things aren't happening? Do you like to bury your head in the sand? Or, are you properly assertive? Are you passive aggressive to where you hold it all in and then you get very confrontational? We have to figure out how it is you're specifically coping. We can help you gain better coping skills. We can help you think about how the stroke has affected the way you feel in the world as you. We can help you learn to manage these big emotions or a feeling like you have a lack of emotions. We can help you embrace and use compensatory strategies, okay? So if you do have a hard time containing your emotions, we can teach you some things that will help to dampen that down a little bit. We can help you think differently about what has happened to you. So many issues of mental distress are because of the way that we think about it. We're not here to tell you a lie or to get you to believe a lie, but we're certainly here to help you not have a negative filter and to see things as more horrible than they really are. Of course, a stroke can be devastating, but there are also ways to figure out how it can fit into a full, positive life. And also, I think we do a really good job at helping your family, people around you, understand that this is real. This is a very real thing that is going on with you. Now let's talk about medications. This is actually a really exciting field of study and has been for about the last 10 years. These studies have taught us more about how the brain works than many other things that have happened in the world of neuroscience. And so most of the medications that I'm going to be referencing are Prozac. Most of the studies use about 40 milligrams. Also, we have nortriptyline at about 100 milligrams, and more recently Lexapro, and the studies have used anywhere from 5 to 10 milligrams. So what is so cool about these studies is we used to think that antidepressants worked by increasing the neurotransmitter serotonin, and the more serotonin you had, the better you felt. Well, because of these studies, we actually know that antidepressants work differently. They actually improve and enhance the health of brain cells, right? Neurons. This is structural chemical changes that are actually happening in the brain. So in a brain cell, you've got your neuron, right? That's the middle part, right, kind of the cell center. And then on the edges of the neuron, we actually have dendrites. These are the little tentacles that kind of reach out and chemically and electrically communicate with other brain cells. This is what makes our brain so interconnected through these networks. And so antidepressants have been shown in people with stroke to increase the health of the brain cells in the brain. And we know this because people have had improved physical recovery, and specifically getting use of a hand back more than people who were not depressed, who did not take the antidepressants. So the way they usually do these studies is they get folks who are not depressed at all, and they're in a rehab setting for stroke, and they give half the group 40 milligrams of Prozac and half the group nothing, and they assess their motor functioning over time. And there's been a lot of support that people who are in rehab, and this is key, you have to be doing an active physical rehab program alongside the Prozac to really get these benefits. That's the best I can tell you from the research that I reviewed. You can't just take Prozac and do nothing and think it's going to help. You actually, there's a series of studies done in 2011 called the FLAME trials, F-L-A-M-E, if you want to look that up yourself. And they were able to really reanalyze the data over time with more sophisticated statistical techniques, and they really found that it had to be in concert with intensive physical rehab. So we've had at least 16 meta-analyses at this point looking at antidepressants, thousands of patients, and basically what they have found is that many people have improved mood, improved cognition, improved motor function, improved quality of life. Caregivers do better. The American Heart Association came out and recommended the use of antidepressants with post-stroke depression, and they said they should be continued for optimal recovery for up to 6 months. We also know that brief talk therapy, specifically things that focus on education, which I love, family support, and connecting you to community resources, also relieve some of the symptoms of depression, which is so cool. Even cooler is a series of studies that are focusing now on prevention, right? So if we know that these antidepressants work so well, and we know that maybe up to 70% of people after a stroke have depression, why not just give it to people prophylactically, right? How progressive is that in terms of brain care? So there was one study I wanted to tell you about that was done a couple of years ago where they looked at 52 non-depressed stroke patients who were treated with 5 milligrams of Lexapro if they were under 65 and 10 milligrams if they were over 65. And they took the medication for a year. And the folks that took the Lexapro had a rate of post-stroke depression that was about 8%. People who did not take the Lexapro, their statistics were all the way up to 22%. So man, is that a big difference. That's a lot of unnecessary suffering, a lot of barriers that could be there against rehab that maybe don't really have to be there at all. So I think that's one of the neatest things about brain science is how we're actually starting to get ahead of the 8 ball and really think about what we can be doing before people are actually suffering and falling apart. So let's end by talking about self-care. I personally think that education is a huge part of self-care. You can tell me if you agree. That's why I do these free lectures, because I want to empower you with the information that I know, being blessed to complete all of my training, and I don't think that it's just something that should live with doctors. I think the people who actually have experienced this brain health challenge should understand it as well as I can possibly explain it, okay? So to me, what I imagine would be the most painful is to be having a symptom but be confused by it, to not know, is this my stroke? Is this my reaction? Is this my chemicals? That's only going to make things worse. And we already have a lot of struggles when we've had a stroke. So to me, this seems like an area of intervention that's just a no-brainer. Let's just teach people more about their brain injury. So if you agree with me that brain health people, doctors, rehabs, should be doing more to educate you about your brain injury, whether it's stroke or TBI, maybe you can give me a little heart, you can give me a thumbs up, just let me know that we're thinking on the same page here. So in terms of self-care, what I want you to know is that your thoughts matter, what you put in your body matters, your ability to move as much as you can matter. All those things can help create a mindset that is more reality-based. Part of depression is you do get this negative filter, right? And that's what's so beautiful about recovery from mood symptoms of all kinds, is when you get better, you realize that you have been seeing the world through dark, no rose-colored glasses here. We're talking about dark gray glasses, right? Gloomy glasses. And it's not necessarily reality. And again, clearly living with a stroke is very difficult and very devastating for many people, but there is absolutely a way to figure out how you yourself can go on with a full connected life through adjustment, education, and rehab. Staying socially engaged is really important, so joining a support group therapy classes, if you can do an exercise class with other people. I always try to make sure my patients understand that even though I am putting myself out there as a certain type of expert in brain injury, really the true experts are you all who are living with them, right? You all have a lot to teach us doctors about exactly what it is you go through. Minding the monkeys in your head is very important. So, it's very important that you respect your emotions, you name them, you identify them. You are allowed to have any emotion. You are allowed to get through the day in any way that you need to. The goal is that hopefully over time you learn to do this in a more healthy way. It's very important to express yourself appropriately to people in your life, the good people that care about how you feel. Learning about our self-talk, what it is that we say to ourselves in our mind is a huge, huge, huge thing. So what makes depression worse? Well, guess what? Getting stressed out, not exercising, bad sleep, avoiding people, not taking your meds, not talking about how you feel, chronic pain, not being involved, not being engaged. And so you have to really fight to stay engaged, even though there might be barriers now to getting somewhere, to speaking for some people, right? So if you are a family member or a caregiver who's watching this because you're worried about your loved one, I hope that you are now a little bit more empowered about the signs of post-stroke depression. I want you to advocate for a psychological evaluation for your person, maybe, even treatment. Listen and support them, but realize you cannot cure anyone's depression. This is not your responsibility. You can help to be a part of the solution, but ultimately professionals need to join with you to take better care of your person. There is something from the American Stroke Association called the Warm Line that I want to make sure you all know about. You can sign up for this really cool free magazine called Stroke Connection. You can get connected with other caregivers. You can find out about support groups. And in the States, it's 1-888-4-STROKE, STROKE. And last but not least is the importance of really pursuing your own joy and your own peace. So many of you are such dedicated caregivers, but I worry about burnout, exhaustion. You need to find ways to fill up your own tank. So that is everything for tonight. You guys are so kind to be here with me and to be paying such good attention. If you think that this was helpful, I would really appreciate you sharing it. You know what? I'm going to take that question from Daisy May Wiggles. She says, what if they have severe aphasia? That is an awesome question, Daisy. And what a cool name you have. Two things come to mind. One is a neuropsychological evaluation to find out if the aphasia is one direction or two directions. So by one direction, I mean expressive, right? There's also receptive speech. So what that means is, what is the comprehension? What is the person actually taking in? If it is an expressive issue only, which is a certain type of aphasia called Broca's aphasia, then you can do things like signing and pointing. Some people can write, some people can sing when they can't actually speak. If the problem is more with receptive speech, where the person really isn't understanding what is happening and what you're saying, that is a way harder situation. And a good assessment can really tell you, is that global, meaning they're really not getting anything? Maybe it's you need to slow down. Maybe it's you need to use words. Maybe you can use pictures in some way. I think it's just such a basic fundamental human need to express yourself and know that you've made sense to someone. Even when I go to visit some of my patients in, we have some local memory care facilities where I am in North Carolina, and I go and spend time with them, it's really obvious to me that they're not understanding what I'm saying, but I still try to play the role that there's reciprocity, right? There's give and take, and say things with my tone of voice and my nonverbal touching to help them feel like we are having a back and forth, because it's such a basic social need that we all have. I see I have another Sullivan on here. I think I'm collecting Sullivans around here. We have Roger, and then we have Ellie, of course. You guys are free to send me a personal message here on Facebook and let me know if there's anything specific you want me to talk about. We are trying really hard to get to 5,000 followers, because we got big plans for this page. I think that there's a lot more out there of you that we could be reaching, and so as much as you can help me promote this page, I would really appreciate it. Sharing it on stroke groups in particular is really awesome. So coming up in May, there's actually 5 Wednesdays, and I am going to again dedicate all 5 Wednesdays to stroke. Partially because I have a really big project coming out soon that I'm very excited to share with you that has to do with stroke, that has taken over a year to write, and it is almost ready for me to feel good about sharing it with you. Very, very, very close. But it's the most common neurological condition, and I really want to get this information out to people. So next time I'm with you, I'm going to be talking about transient ischemic attacks, called a TIA, and how that really is a warning I need you to take seriously. Then I'm going to talk the next week about how to reduce stroke risks in women. I've been researching this recently. There's a lot of hormonal issues that are unique to us that I want to make sure that I'm letting you all know about. The next one, I want to talk about the needs of the caregiver during the inpatient stroke rehab. And this one was really inspired by someone that I met on a stroke page recently named Armani and her beautiful partner, Tony. They are just exemplary, just doing such a beautiful, committed job in his recovery, that she really got me thinking about, what do the partners, the spouses, the wives, the husbands need from us as a community when they are in that type of a setting. Then I want to talk to you about the role of a care team in your stroke recovery. Who are all the players that I would recommend? Who can you get what help from when and who? And then the last one, we're going to talk about stem cell therapy in stroke. Is this hype? Is this hope? I'm actually going to do a whole bunch of research to get you the best information that I can. I don't know a ton about it right now, but you can be sure by the end of May I will. So thank you guys again so much for being here. Please share the page as much as you can. That is really what keeps us going, to know that these efforts are being well received and to know that we're doing something positive to alleviate unnecessary suffering. Thank you guys so much, and I'll see you next time. Bye-bye.